Good afternoon, everyone, and welcome. We will be starting our webinar shortly. We will wait a few more minutes as people begin to log in. All right. Well, welcome everybody to our webinar on understanding and applying social determinants of health, screening data, and address barriers to health, hosted by AAPCHO, HOP, MHP Salud, and Healthcare for the Homeless Council. So before we get started, we want to go ahead and for some housekeeping for our Zoom webinar. First is the audio. If you click on the mute and unmute button, that will allow you to use your microphone. However, to minimize background noise during the presentation, all attendees are muted upon entry. If you click on the up arrow button on the right side of the mute unmute button, that allows you to choose specific audio settings for your microphone and your speaker. Next is the Q&A feature. During the presentation, you may ask questions simply by clicking on the Q&A. Type your question into the free text into the text field. The moderators, organizers, and guest speakers will either send a typed response or answer to your questions live. You are all as attendees can also upvote and comment on open questions if you wish. We will only have this hour together, so we encourage you all to monitor the Q&A pod and virtually engage. An hour and a half, and virtually engage on each other this way. Next is going to be the chat. By clicking on the chat, you can communicate with all panelists and attendees at any time during the session. Do chat us for troubleshooting issues, for questions. We encourage you again to use the Q&A feature and not the chat box. Next is going to be the raising hand feature. If you have a question during the live Q&A portion towards the end, you can click on the raise hand and the moderators will do their opened your audio for you to ask a question. Afterwards, click on the lower hand to be dismissed. If that fails, simply type your question in the Q&A pod. And lastly, to leave the webinar, just go ahead and click on Leave Meeting. So in case you missed it, last year, we went ahead and created a resource that we went ahead and shared with everybody after our webinar and our For Learning Collaborative series. The objectives of that resource was to explain the importance of tracking health center interventions in addressing patients' social determinants of health risk. We also focus on describing the role of primary care associates and health centers in identifying patient social risk and promoting a standardized protocol to track enabling services. And we also identified resources available for PCAs and health centers to implement an enabling service data collection protocol with their own organization. The next here is going to be the faculty, the presenters that are going to be here today. As we reach our portion of the presentation, that's when we're going to go ahead and take the time to introduce ourselves. So about the learning objectives for this webinar, we are going to go ahead and try to highlight the enabling services workforce as a key drivers in assessing and addressing the social determinants of health. We're going to go ahead and demonstrate the overall value and impact of enabling services. We're going to go ahead and conceptualize the use of data to support value-based care. And we're going to go ahead and provide an overview of relevant data collection tools used for assessing and addressing the needs of special and vulnerable populations at health centers. The agenda, we're going to go ahead and give an overview of what enabling services are, and also social determinants of health. After that, we're going to go ahead and demonstrate the overall value and impact of enabling services. From there, we're going to go ahead and conceptualize the use of data to support value-based. After that, we're going to go ahead and overview of data collection tools for assessing and addressing needs for special and vulnerable populations. And then we're going to go ahead and mention our up and coming learning collaborative and open up for any questions and concerns that you guys might have.
Thanks so much, Hansel. You can go to the next slide. So we're going to quickly go over enabling services workforce and the social determinants of health. My name is Sakura. I'm the program manager of training and technical assistance at AAPCHO. So with this slide, just to get everyone on the same page, when we talk about enabling services, we're really talking about these non-clinical services that health center provide that really make accessing patient care possible for many of your patients. So you see with the examples here, interpretation, outreach, referrals. These things enabling services almost always address the social determinants of health. So if you go to the next slide, I think there's a chart, if you could go back one, Hansel. So enabling services are really social interventions. So when you provide access to preventative care through these services, you can decrease the cost of care by improving health outcomes. And I'm sure as many health center folks and any health folks can attest to, these are really important services. And if you go to the next slide, can you move forward, Hansel? One, thank you. So this is a table by USF Siren Network, and it's comparing and contrasting the different social needs screening tools that are available. And if you go to the link, you can see a really exhaustive list as well. And as you can see, at the very end, the last column, we have Prepare, which is focusing on community health centers. And it also has 25 languages available. If you go to the next slide, please, Hansel. If you could go back one. So this is from the Uniform Data System from HRSA, which collects information from health centers and lookalikes about information such as certain general patient characteristics or services provided. And this table here really shows that the health center workforce is increasing. And even though it's not highlighted in green at the right, we can see that enabling services also has an 11% increase. So we want to go more into that in the next slide. So the UDS captures 8 enabling services workforce, and health centers have to report the full-time equivalent of these providers with their visits and numbers of patients served. But beyond these 8 categories, AAPCHO and other NTAPs were really advocating for HRSA to collect and standardize more data to demonstrate the value and impact of these really essential workforce, which we're going to go into further detail. And next slide, please, Hansel. In this slide, we're really going to look at the wide breadth of the change that's happened from 2015 to 2019 with the enabling services workforce based on UDS. And as you can see, case managers, transportation staff, interpretation staff, and community health workers have really skyrocketed in number since 2015. Go to the next slide, thank you. So in collaboration with health outreach partners and National Healthcare for the Homeless Council, there was a lot of advocacy for expanding the number of categories in order to more fully reflect the type of services that health centers routinely provide. So we're really advocating for not just 8, but 15 categories. And these categories were vetted by an advisory group of health centers just a few years ago. So in addition to adding these categories, we're also including things like volume and length of time for all these services, the setting of the services. So are we meeting face-to-face, in-home, phone, or email? And then things like whether the service is provided in a language other than English. And this expansion happened in 2015. And again, we want to reiterate that these 15 categories aren't exhaustive, but they're what's really necessary to align with the UDS reporting. And with that, we can see that these are the new and old categories using the Enabling Services Accountability Project. And thanks to the partnership with health outreach partners and National Healthcare of the Homeless Council, as well as the steering committee of health center representative, we really want to capture enabling services in a more wider and deeper breadth. Again, this is not comprehensive, but we're really looking at health as social care to address social determinants of health. And this isn't standardized nationally, but there is definitely a need to document. And we recommend that health centers start now so you can report more in depth later. And then overall, enabling services data collection is just really important for many examples. One, to make the business case for sustainable funding for these services, and also to demonstrate health-centered value, clinical transformation, and patient-centered care. And then also to provide data for reducing barriers to care, and as well as racial and ethnic disparities, and then provide data for reducing, highlight the value, of enabling services, and then bringing attention to the need of comprehensive care for vulnerable, underserved, and diverse populations. If you go to the next slide, Hansel. So UDS collects some information about SDOH data collection, and it shows that 70% of health centers reported collecting data on individual patients' social risk factors. 23% are in the planning stages, and UDS also shows that 34% of these health centers reported using Prepare, and 6.5% of these health centers reported using the AHC screening tool by CMS. Next slide, please, Hansel. So the UDS asks, does your health center collect data on individual patients and social risk factors, as well as which standardized screener for social factors do you use? But starting next year, next slide, Hansel, they're gonna go a little bit more in depth. So please provide a total number of patients that screen positive for the following based on your data collection, as well as why health centers or their lookalikes are not collecting this information. And with that, if you go to the next slide, we also want to ask everyone, folks in the room, which standardized screeners for social risk factors, if any, do you use? So Hansel, if you could release the poll, please select all that apply. So A, accountable health community screening tools, upstream risk screening tools, I help, recommend social behavioral domains for EHR, prepare, we care, WellRx, as well as other. And if you have other, if you could please describe in the chat box, as well as if you don't use a standardized screener, we'd also like to know as well. So I'm gonna give about 30 seconds for that. Thank you, folks. Seeing a lot of Prepare and some accountable health community screening tools. I'll give about 10 more seconds. Thank you, folks. And Hansel, if you could end and release the poll. So we have 49% of folks using Prepare, 10% other, 8% accountable health community screening tool, and we also have 32 who say we do not use a standardized screener. Highly recommend registering for our upcoming learning collaborative to learn how we can do that. Thank you so much. And then, so going to the next slide. Oop. Move forward, Hansel. Thank you. So going back to the basics again of why should we collect standardized SDOH data? And we kind of want to look at this from multiple levels. So first, kind of at the patient and family care team member individual level. So what does a patient specifically need? So if a patient responds, hey, I'm having issues with my utilities, but they have diabetes medication that needs to be refrigerated, well, this is something that health centers can provide support on or identify as a potential challenge. And then organizational level and the system community level, we can see with the data, hey, does our health center need this kind of worker? Do we need more translators? Do we need more community health workers? And then systemically and at the community level, what kind of partnerships do we need to make to support our patients in the communities that we serve? And then also at the payer level, what kind of payment transformation can really address our patient needs? And again, at the policy level, helping our legislators and constituents know who their constituents are, and then reimburse for health and social care, and seeing that social determinants of care, health is really healthcare, which really goes back down again to the individual level. So again, kind of the cyclical nature of why this data collection is really important. And then next slide. I'm not going to read this exclusively, but it's just essentially saying that all health centers serve different communities with different needs. There is overlap, obviously, but with this data collection, it really helps to focus on what the specific issue is or the needs are for your health center and helping align what Prepare can do. So moving forward. This is the 5 rights framework used by Prepare. This helps all implementers walk through really key questions to consider when determining your workflow. So the first is the what. So a lot of health centers already ask these questions. So what are the necessary SDOH questions that need to be further collected? And then in the right format. So how are we going to administer it? Is the patient going to take it themselves? Or is someone at the health center going to ask these questions? And then who is with the right people? So who's going to collect this data specifically at the health center if they're doing that, and who has access to the data? And then the when is kind of for in-person visits. Are we going to ask beforehand? Are we going to ask afterwards during the visit? And then the where is kind of the right channel. So where will Prepare data be collected? How will it be shared with the appropriate care team members? So the next slide, thank you, Hansel, is some samples of these workflow models that you can reference. And then the next slide is a specific example of using enabling services staff for screening post visits. And then this shows that there are really advantages and trade-offs to each situation, but with community members and your health centers, you can really discuss, hey, what's the best option for collecting this data? And then the next slide, Hansel. So this is SDOH data collection kind of in action. So Prepare pioneer and provider champion David Falmado for more than 25 years has worked at the Siouxland Community Health Center in Sioux City and currently serves as a quality director. He was also instrumental in shaping and piloting the Prepare project. So we kind of wanted to highlight their work here and to see what working in Prepare makes them a CHC champion. And then the next slide is some more additional resources and tools to help you collect the SDOH data. And again, we highly suggest registering for our upcoming learning collaborative, which is going to help you do a more deeper dive into this topic. And now I'm going to pass it back to Hansel, who's going to discuss demonstrating the impact and value of enabling services. Thank you so much.
Thank you, Sakura. So today we're going to, so learning objective number 2, we're going to go ahead and demonstrate the overall value and impact of enabling service. My name is Hansel Ibarra, and I'm a program director here at MHP Salud. I've been part of MHP Salud staff since November 2020. So enabling services address a combination of social determinants of health and barriers to access to primary care. They intend to reduce health disparities. Their impact can be seen in the following 4 categories. The first category is our health outcomes. How does enabling services impact health outcomes? First off, health outcomes measure a change in health status of an individual or a group, which can be attributed to an intervention. So a positive health outcomes includes being alive, functioning well mentally, physically, socially, and having a sense of well-being. A negative health outcome would be a death, loss of function, or a lack of well-being. There is evidence demonstrating how enabling services programs have had positive health outcomes. A recent intervention led by HIV positive or HIV affected CHWs in 3 Southwestern communities sought to decrease stigma surrounding HIV and increase knowledge on HIV and the perception of risk. Results of this intervention found that the stigma decreased and knowledge increased among the 579 underserved Latino adults that took part of the intervention. This further proves that when combined with treatment and care of an HIV team, CHW-led outreach activities, education, and community support are a powerful strategies for preventing HIV. The second and third category that enabling services has an effect on is going to be your service delivery and the quality of care. Enabling services positively impact the delivery of service by ensuring that the patient understands what is expected of them and allowing them to voice out any concern. This in return also causes a effect in the quality of care being experienced, since there's communication and understanding between the medical care providers and the patients. CHW can help make healthcare systems more responsive by communicating information from the community back to the healthcare providers and vice versa, thus improving service delivery and the quality of care. A CHW working with a diabetic patient can ensure that the patient understands the risk of mixing medication and teach them ways to stay active, as well as provide them alternatives, healthy alternatives for common dishes. They can also listen to any concerns the patient might voice and communicate them back to the healthcare system. CHW programs that have used enabling services to prevent and to manage diabetes have shown at least one positive outcome, ranging from lowering HbA1c levels to improve self-reports in dietary changes. And as I mentioned, there's a fourth category as well. And that fourth category is going to be the return on investments. A return on investments, or ROI calculation, is a total value or benefit resulting from a program or intervention divided by the total cost, So for every dollar invested, there is a benefit created. An example, a return on investment score of more than 1 tells you that the program's calculated benefits outweigh the cost. A return on investment of less than 1 tells you that the program costs more than the calculated benefits it's producing, and a return on investment of less than 1 shows us that the cost, or a return on investment that is equal to 1 shows us that the costs are equal to the benefits. Now, a program who scores less than 1 or 1 doesn't necessarily make it an unsuccessful program. There are benefits we simply cannot quantify or might have missed. Return on investment can be as simple or as complex as necessary for your program and your organization, depending on what data is available and what type of data you want to calculate. We know that enabling services serve a function on a health team that is not always available through other members or sources of a health center. Showing their impact and value is always important. One possible method to further evaluate and understand their value is looking at their economic impact, which is also known as a return on investment, which calculates the total benefit derived from each dollar invested into the program. A return on investment, together with success stories, testimonials, and other type of data and information showcasing the great work that they are doing, comes together to demonstrate the overreaching value of enabling services. So why do we choose enabling services, or why choose return on investments to show the benefit of enabling services? Well, it is relatively easy to use and understand. It is also very versatile. It can be individualized, and it could also be used to calculate financial and non-financial components. It also provides you an estimate of the direct financial impact that the program is having. And it also supports sustainability by showing how funding the program creates its own savings. Understanding and participating in a return on investment process arms you with the knowledge you need to defend your program as a key way to serve your communities. The current national attention paid on improving health outcomes and the quality of care, while also containing costs, make positive return on investments even more significant. Measuring return on investments of CHW-led programs and sharing the results contributes to the growing body of evidence that investments in these programs are both impactful and financially suitable. Return on investments results additionally provide a great snapshot of information to share with both the stakeholders and the community to demonstrate both social and fiscal responsibility. So who are the stakeholders when it comes to return on investments? The first stakeholder that we have is the community level, which is also known as the society. And this focuses on the broader community impact of the enabling services. So here we look into how much the benefit or the return is to the entire community that's receiving the investment. So an example can be preventing hospitalizations because patients, community members are following their care plans due to the enabling services outreach, case management, and follow-up. The next stakeholder in this is going to be the institutional level. This level's attention is on the institution that is providing the enabling services and the impact that it's having for them. So we're basically looking at what return did the host clinic or network receive based on their inputs. An example can be increase of patient attendance to the doctor's appointments due to enabling services staff, reminders, and follow-ups. And the last stakeholder in this, in return on investment, is going to be the individual. In the individual level, the concern is the individual receiving the enabling services and their impact. So here we're looking at what savings did the individual receive based on the inputs of the program. And an example of this can be the decrease of out-of-pocket costs for diabetes care due to enabling services, staff education, follow-up, and case management. A community health worker and other helping professions tend to think with their heart. A common quality of a community health worker is compassion. They see the community need and they want to help as many people as possible. But many others think with their pockets or their wallets. Return on investments allows to persuade those who have the wallet pocket mentality and to show them the worth of the community health worker has in the community. A community health worker can also assist in the development of return on investment, as it requires many people from different perspectives to brainstorm the proper structure of return on investment. Whether simple or complex, a CHW should always have a place on the table when it comes to figuring out your return on investments. The examples that I have here show you how incorporation of enabling services into the medical team have shown great success. The first one is the Denver Health, and they go ahead and show a return of investment of $2.28 for every dollar spent to decrease urgent care and uncompensated cost. Arkansas Community Connected program, they went ahead and showed a return on investment of $2.92 saved for each dollar that they went ahead and spent. And Spectrum Health, which is located in Grand Rapids, Michigan, shows a return on investment of $2.53 for every dollar that was spent in diagnosing diabetes and heart failure. So at this time, I'm going to go ahead and post a poll for you guys. Give me 1 second as I get that going. So I would like to go ahead and ask you guys, have you or has your organization used return on investment to demonstrate the value of enabling staff? So you can either say, yes, you've used it, no, you haven't, or you're not sure if your organization has used this type of services before. So I'm going to go ahead and give you guys a minute or so I can go ahead and get that answers from you guys. And as a little reminder, enabling services deal with transportation, translation, case management, case support, counseling. So things like that would fall under enabling services. So I'm going to go ahead and wait a couple of more seconds before I close this out. All right, so let's go ahead and see the results. All right, so share results. So we see here that a big portion of you guys are not using any enabling services, or you're not sure if your organization is doing so. Thank you for participating on my survey. But I have good news for you guys. If you are some of the individuals who have no experience or little experience dealing with return on investments and CHWs, or for those who already utilize this type of services, MHP Salud offers a free tool titled Return on Investment, a guide for conducting a return on investment analysis of your community health worker program that will help you elevate your return on investment game. The toolkit was designed to help you figure out the return on investment of a community health worker program unique to your organization. This tool provides pointers on how to build your return on investment team. It also provides assistance with figuring out what numbers to use when you're trying to calculate a return on investment. It also shows how return on investment is a great way to get to know your financial information, and it gives you examples of return on investment calculations and health centers who have utilized that tool itself. And I believe we went ahead and shared that link on the chat, but we're going to go ahead and also include it on the follow-up email. Now, also for those who are interested in starting a community health program, MHP Salud also offers a collection of resources which provides guidance, information, and tips for organizations interested in starting or organizations that have already invested in a community health worker program. MHP Salud has been implementing community health worker programs in underserved communities for more than 35 years, and we have been providing training on community health worker model for more than 20 years. Our work extends from a single organization, assisting every step of the way in planning and executing effective CHW programs in the communities, all the way up to the state and national initiatives focused on standardizing the CHW model and advancing the profession as a whole. Some of the topics that our resources cover are going to be the organizational concept fitness. This guide basically asks, are you ready for an organization to implement a community health worker program? And it uses checklists and questions to help your organization think about the elements that are already in place, which might be needed to develop a CHW program. Another resource that we offer here is going to be the CHW Program Readiness Checklist. This is basically, does your organization have all the required components in place to launch a new community health worker program? This checklist will ensure that all your bases are covered. Another resource that we offer is going to be a guide to hiring qualified supervisors for CHW programs. This is a specialized application process that will allow your organization to fully understand if the candidates are qualified to supervise CHWs with the information and activities that are presented in this guide. The second to last resource that we offer is finding qualified candidates, how to hire community health workers. This resource is going to go ahead and help you find candidates that have the unique qualities to fill a community health worker position with the resources that provides activities to incorporate into your hiring process. And the last resource that we offer for community health workers is going to be your CHW Pre-Hiring Checklist, which is a created checklist which shows you a plan and strategy before moving forward with hiring the CHW, and it gives you a pre-checklist for that hiring. So as I mentioned, the value of enabling services work not only improves the individual practice of a health profession, but also improves the way that the care team works together and the way that the healthcare organization or health centers serves the community. We know that health centers provide primary and preventive care to a diverse populations. These special populations may face a wide array of cultural, economic, linguistic barriers that may inhibit patients from achieving good health. Therefore, enabling services staff have the potential to bridge the gap and link patients to care and continuity of care for improving health outcomes, which is the ultimate goal for health organizations. For those who are already offering enabling services, we encourage you guys to share your success stories with other health centers and advocate for the profession, periodically sharing the success of enabling services with other health center leadership and the entire care team gives value, respect, and credibility to the profession, which essentially contribute to the strengthening of enabling services in the workforce. And that is going to be it for my section.
All right, well, I think that brings it to me for learning objective 3. So you can go ahead and advance. Hi, everyone. My name is Bellany Reese. I am a project manager with Health Outreach Partners, or HOP. And now in talking about the value of enabling services, I'd like to speak a little bit on how we can leverage this as sort of the foundation for the ways in which health centers deliver services and receive payment for these services while always prioritizing access and quality. Next slide, please. Now, before we talk specifically about value-based care, it's helpful to understand a little bit of the context from which it arose. And we can begin here with the triple aim, which is a framework that was developed in 2007 by the Institute for Healthcare Improvement. And it describes an approach to optimize performance of the health system in 3 different dimensions. The first being to improve the patient experience of care, and that includes both quality and satisfaction. And this builds off of the Institute of Medicine's 6 domains of healthcare quality. Second, we have to improve the health of entire populations, and this is really to help us get closer to the cause of health problems. And then lastly, to reduce the per capita cost of healthcare in hopes that these financial resources can really be used to fund other necessary services to promote population health. Next slide, please. And let's see, so we can probably spend all day, or at least the entirety of this 90-minute webinar, brainstorming ways in which we can alter service delivery to improve patient experience in terms of both quality and satisfaction. This is what some people devote their entire careers to. And the same could be said for improving population health. The key really here is how to achieve both of these while also keeping costs low and remaining financially viable. And so in diversifying healthcare service delivery in the type, the amount, and the ways in which these services are delivered, the health system has adopted and adapted different payment models to move toward achieving the triple aim, or what some of you may know as the quadruple aim, with that fourth dimension being increasing provider satisfaction. And now if we look at the traditional model of fee-for-service, where the payer reimburses the provider for each billable service, we see that changes to service delivery models don't necessarily result in corresponding changes to payment, since not all services may be billable. Additionally, fee-for-service models really tend to be tied to face-to-face visits. Enabling services provision, things like outreach, interpretation, financial counseling, etc., may not always qualify for reimbursement. And thus this payment model really prioritizes a high volume of patients, or quantity over quality. But if we look at some of these other alternative service delivery and payment models that have emerged, they've come in to really help kind of fill in the gaps and reward the provision of high quality services. So, we can think of some service delivery models like the patient-centered medical home designation, accountable care organizations, or Medicaid or Medicare managed organizations. And some of the ways these service delivery models are able to manage costs is through payment models like capitation, or maybe a per member per month payment. Also pay for performance, in which reaching pre-established performance measures is really rewarded, usually based on certain population health indicators. And we may also see other types of shared savings payment models, such as bundled payments. And these alternative payment models really allow for a good deal of variation in the service delivery model, and also provide an avenue for payment. And in this way, they really help to incentivize the provision of high quality services, and not necessarily quantity. And so now what we would like to know, if we could launch our poll, is what types of value-based care or payment models are you involved with at your health center? And we'll go ahead and give you a few choices here. So, if you collect SDOH data, if you're engaging in population health activities, if you have a patient-centered medical home designation, or if you're a part of a managed care organization, shared savings, please check all that apply. And also, if you aren't sure, go ahead and let us know that as well. Or if there's another type of model that you're engaging in, please type it into the chat and let us know. We're very curious. And maybe we'll give that about 20 more seconds for folks to answer. And we'll keep monitoring the chat too. I know it takes a second to type out sometimes. All right, just a couple more seconds, get your last answers in. All right, we can go ahead and end. All right, so it looks like, we'll go ahead and share these. It looks like there's a lot of patient-centered medical homes. And then next up, we have a collection of SDOH data. Great, that's what we like to hear. A few care organizations here or there, and some other. So I'm really looking forward to reading what some of these other models are. We can go ahead and advance to the next slide. All right, so really the question is, what exactly is value-based care? And so the Centers for Medicare and Medicaid defines value-based care as programs that reward healthcare providers with incentive payments for the quality of care they give, using data and metrics to measure quality improvements and performance. And these really aim to improve individual and population health outcomes while also reducing costs in the long term. Next slide, please. So the question is, why does this really matter to health centers? Well, value-based care is of particular importance to healthcare centers, health centers for a few reasons. First, as the primary source of healthcare services, for millions of people, including many underserved communities, health centers have very high utilization rates. And with so many patients accessing health center services, there are always opportunities to ensure, improve, and maintain quality care and patient satisfaction, and also to find effective payment models that match. Secondly, health center patients are diverse in their needs as well as in their resources, including the type of insurance that they have. And so in order to remain viable in a constantly evolving healthcare landscape, health centers should really review the mix of payers that they have in order to find payment models that fit best, which includes taking advantage of value-based initiatives where appropriate, especially to be able to provide enabling services to address the social determinants of health of your patients in a long-term and sustainable way. And last, but certainly not least, health centers have been instrumental in implementing a lot of the key aspects of federal health policy, particularly the Affordable Care Act, such that placing priority on certain services like enrollment has reduced the capacity to be able to provide other services like outreach, case management, transportation, et cetera. And so health centers working together with their PCAs and other state organizations have really been able to advocate for alternative service delivery and payment models, and to be able to provide these critical enabling services. And so given that a great deal of health center revenue comes from Medicaid reimbursement particularly, health centers individually and collectively can really help to paint the picture of the health needs in a given state, which has, for a lot of states, really led to a focus on contracting with Medicaid managed care organizations in order to better be able to manage costs across the board. Next slide, please. So really, when we're thinking about value-based care in the context of health centers, there are a few basic but helpful questions to ask, to ensure that you're providing the high quality care to your patients, while also figuring out how to maintain appropriate funding to do so. So we're looking at things like, do you account for social determinants of health? Are you enabling, does this enable the health center to be reimbursed for the various services that are provided to address these social determinants of health? Does your payment model reward patient outcomes as well as the value of care? And are you leveraging your state's Medicaid policy for optimum reimbursement? Next slide, please. Now, how does all of this data collection really fit in with value-based care? Well, speaking first at more of a specific health center level, we can look at the use of Z codes to document patients' social determinants of health and non-clinical needs, as well as the provision of enabling services to address these. And documentation of of the need really helps to generate an understanding of the health landscape and the patient population in order to identify the appropriate services to provide. And then documenting these services really allows for the appropriate billable services to be reimbursed, and also maybe to highlight those services that aren't being reimbursed. And as Sakura mentioned, there's some really helpful tools to help document some of these Z codes because it can be challenging often. Next slide, please. So once you have your SDOH and enabling services provision data documented, health centers can work to or work with the health information systems team to review health center level data to look for trends and maybe opportunities to involve or improve value-based payment. And so the first report that can be used is the UDS report for your specific health center to look at the mix of payers. And this is also a good opportunity to assess the health center's policy and processes for inputting SDOH and enabling services data so that you can be sure that you're making a good case for reimbursement for as many services as possible. Next slide, please. And lastly, health centers really can both monitor and contribute to cost sharing data in their state, and that again can have a direct impact on federal and state level Medicare and Medicaid policy, as well as the availability of value-based payment options. So we can take a look at this graph here and see this is data on the Medicaid or Medicare managed health or care organizations member type from 2018. And we can see that Medicaid reimbursement really dominates the payer mix. And so this suggests a pretty big opportunity for the involvement of cost sharing with other MCOs and a focus on healthcare performance, quality, as well as outcomes. Next slide, please. And so just to close out here, I'd like to point you to some different resources from HOP that have a focus on value-based care. The first being our value-based care primer, which was just published last year and offers a uniquely specific lens of the impact of alternative payment and delivery systems or models on FQHCs. We also have our outreach and value-based care resource, which provides specific examples from health centers across the country who were able to integrate their outreach services into the larger service delivery model to be reimbursable. And this resource also accompanies our outreach business value toolkit. So if your health center is looking to grow its outreach practices or make them more sustainable, please go ahead and look into either one of these resources or both. I know that with the onset of the COVID-19 pandemic, outreach models are really evolving to kind of adapt to telehealth and other formats. So please know that these resources are here for you if you need them. And with that, I will turn it over to Brett to cover our last objective. Thank you.
Great, thank you, Melanie. So for our final objective for today's session is just going to be providing an overview of a lot of the data collection tools that have already been covered, just going to highlight and reiterate some of those, but also kind of shift the focus to then how we assess and address those needs for our special and vulnerable populations. As she said, my name is Brett Poe. I'm a research associate with the National Healthcare for the Homeless Council, and also going to provide a little bit of a framework for how this can apply for our vulnerable populations. Why data collection for SDOH is important. Again, as everybody has already mentioned, I'll be introducing some more toolkits and additional resources to help with some of the things that some of the other people have already mentioned, and we have some additional resources to dive a little deeper into that. And also some highlights from folks that have already implemented some of this into their care planning, and then kind of wrap it all up with how we can bring it home and lead into our upcoming activities. So we can go ahead and move forward, Hansel. So again, just sort of providing the lens of this on special populations, of course, with us having our focus on people experiencing homelessness, We know that those types of populations cross a lot of the domains and intersections that were identified by the CDC as what constitutes social determinants of health. So their neighborhoods and their built environment, their health and their healthcare, their social and community context, education levels, economic stability, income levels, things like that. And we know that for all of our special and vulnerable populations, a lot of those factors are at play as well. So we can move on to the next slide. And so why that would matter to health centers is we know that across all of those domains, if the level of security is going down, then the negative health outcomes in these areas of direct chronic conditions like hypertension, hyperlipidemia, mental health, overall poor health or heart disease, those negative outcomes go up as the level of securities in those other domains go down. And we can move on to the next slide. And so this chart here, as Sakura mentioned, I believe that she also had a list at the beginning of all of the different types of data collection tools. We know that a lot of people, it looked like a lot of people on today's session were using Prepare, but there's obviously different ways to assess what's most important for you. So essentially, this is just sort of a demonstration of a crosswalk that can be utilized to make sure that what you're using checks off the most boxes for what's relevant to your populations, also taking into consideration the capacity of your staff or different areas of your workforce that you might be able to pull in to address some of these issues that are asked by these SDOH screeners. And we can move on. And yeah, so as I think also Sakura mentioned in her section, using the right staff is another tool that you can use, making sure that you're using the appropriate workforces. As many people have mentioned, community health workers, and Amelia, I know, asked in the Q&A about the benefits of using community health workers and collecting this. There's a lot of different approaches. Again, it just depends on the nature of the relationships between your providers and your population base. Are there power balances to consider, de-escalations that might be in place, how it makes people feel when they're asked questions across those domains? And then also the relationship with the provider staff versus medical assistants, or knowing when to ask the question. Is it sort of throughout the visit? Can it be scattered? Can it be coming from the community health or peer workers? Is it better to do it at intake while they're in waiting time? Or directly from the provider? A lot of different places implement this differently. And so I'll kind of refer to the lessons learned document that Hansel referenced again at the beginning of the session, that we kind of found through our learning collaborative last year, that there was a no one size fits all. So you want to just kind of take all of those considerations, and again, with your population base, your workforce, and your capacity as you address those questions. And you can move forward. And so also, as Bellany had just mentioned, we do have a link here to an Ask and Code policy brief. This was developed by the Council's Director of Policy, Barbara DePietro. And this document addresses a lot of these different areas of what's the most appropriate way to ask the questions for SDOH. So instead of saying something like, are you homeless? That might be off-putting, or it might be too general. Some people might not self-identify as homeless. So asking questions in a different way of, where did you sleep last night? Or how confident are you in your security and where you'll be sleeping, in a week or in 2 weeks? And it also addresses how to best train staff in those areas. And I have additional resources that I'll be highlighting here in just a couple of slides for that as well. It's important to have a formal procedure. Again, it doesn't have to be standardized across every community health center everywhere, but you do want to have a formal procedure that's in place that works best for your health center, so there's consistency and ways to follow up. And then also, as she mentioned, using those Z codes, this document provides a lot of good detail on that, and differentiating which codes mean what, and also provides lots of examples of sample questionnaires. So I don't know if, Albert, you're able to access the link to that brief, but if you could post that in the chat, I think that'd be a really great resource to share. And we can move on to the next slide. And again, just kind of highlighting briefly what other things are in that document. What are we asking, how it addresses the common questions that people have when they're starting to implement these types of screeners. So how to ask the common questions, and then what strategies do you have to utilize that data and then best implement the most appropriate screening and response practices for your site. And we can move on. And just again, some of the detail of what that policy brief goes into as it relates to those ICD-10 Z code series. And you can move along. And then some additional training materials that we have. These were developed by the Healthcare for the Homeless Clinicians Network. Practices that you would want to incorporate while you're approaching how you want your staff to address these SDOH questions would definitely be in a trauma-informed, culturally appropriate kind of manner. Also utilizing motivational interviewing style questions, so they don't feel like you're designating a care plan for them, but instead working with them to identify, what goals they want to reach and how can they best reach them as it's appropriate for them and their available resources. And just keeping in mind that even asking the questions can often be trauma-inducing or anxiety-inducing. So wanting to establish that they're in a safe place, the people asking these questions are trustworthy. It's important to establish why these questions are being asked and how that information will be used as it relates to their care plans, and how they can feel like they're empowered and collaborative in that process. And we can go on to the next slide. And that previous link was for a document called Healing Hands that the Clinicians Network puts out a couple of times annually. That one was the most specific to trauma-informed approaches of questioning and motivational interviewing, but it was from 2010. So I wanted to provide some additional links that are more recent. So this first link here is how SDOH screening can be used as it relates to preventative care. And that came out in fall of 2017. And the main lens on that is preventive care, but it does reference how SDOH screeners can be used and then how that data can be used to develop those care plans. And then similarly, the focus of the next two links, both from 2019, are how you can utilize trauma-informed care and motivational interviewing as it relates to non-opioid substance use, and also various trauma-informed treatment models. And again, all of these links will be available in the slide deck that will be sent out if they're not already being posted into the chat. And this is another great resource that was developed. I believe it was just put out live last summer. And this is a trauma-informed organizational toolkit. This was developed by one of our staff on the policy team, now on the community engagement team, who is the liaison for our National Community Advisory Board. And this was something that they did through another learning collaborative with the input from the Consumer Advisory Board on how can you tell if your organization is trauma informed. So they developed this toolkit that covers these domains of understanding what the trauma is, how you can manage change in your organization should it be needed, how do you create the capacity and the structure to be a trauma-informed organization, and then also it includes an assessment that you can use for your own organization with all kinds of related information on where to go depending on where you land in that assessment, as well as the contact information for the folks that developed it. And again, it was developed from a 3-year learning collaborative from the previous cycle. So there's best practices and tons and tons of links that break down various ways to approach assessment, readiness, change development, and implementation. And so for my poll question, I just wanted to open it up to you guys. I know that before they said that you could only select one. Hopefully you can select all that apply if possible, but wanting to know a lot of people's hesitance to even ask SDOH questions is not knowing what to do if they don't have the system in place already to address those needs. So I'm just wanting to know, what do you do in the event that you don't have the available resources? Do you refer to existing partners, provide community information of available resources in the area? You might just get their contact information and follow up when you have potential resources in the future. Some people think it's important to document the needs that aren't currently addressed. I tend to agree that I think you don't know what you need until you know what's needed. Or others also just don't feel like it's appropriate to ask the question if they know that they don't have the capacity or have partners in place. And as before, if you do something else, please feel free to type that in the chat. So leave this up for just a couple more seconds. Okay. So I'll share those results here. Yeah, it looks like most are saying, or about just under half are saying that they'll provide community information of the available resources. And that was an option that we added in actually from one of the best practices, I think that was identified in one of our previous learning collaboratives. That wasn't one that we thought about. I've heard other people present on that before. Most were just referring to existing partners, but I do think that if you don't have those partnerships in place, it's important to show that you've done some of the homework and that they know that you're at least trying to point them in the direction of resources that can help them. All right. So we can move on to the next slide. So this is a prepare brief, the link at the bottom of the slide here. And the next few slides are just going to summarize some of the lessons learned and considerations that were introduced again from another previous learning collaborative and a series of listening sessions with a focus group that was led by the Healthcare for the Homeless Council and our partner Corporation for Supportive Housing. And the intent of that learning collaborative and this best practices document was just to gain what those practices are, of how to answer exactly that previous question, what to do if you don't have the existing resources, and how you can go about establishing those needed partnerships or infrastructure if that capacity doesn't currently exist. So we can move along to this first slide here. So this is just the experience of utilizing the data collection tools, and I'm not going to read every single piece of this, but just to pull out some of the key points. Challenges for utilizing the data collection tools just being the lack of training, but then successes being that if they know high-level details of the tool and they're able to access skill development in trauma-informed care and motivational interviewing, again, like the resources that were shared a few slides ago, that was helpful for their staff to learn how to ask those questions and how to utilize that data. And then also understanding the challenge of data collection burden and knowing that there are distinct tools that are already used from medical histories and making things conversational with the patient was also more successful than asking it as if it was just a list of clinical questions. Also recognizing, as we saw in the crosswalk a few slides ago, there are multiple tools. And so again, there being a higher success if there's a concentrated effort early on to make sure that you're choosing the right tool, and again, increasing access to trainings on those tools. And also just understanding that data storage varies between health centers. And also to address, I believe it was Amelia again, who asked about EHR incorporation of SDOH domains. They did say that if you have that capacity to do that, prompting providers and integrating that into the care plan, that it is helpful. But there was also the acknowledgement that it took significant effort. So I believe the question in the Q&A was, what's the benefit of incorporation versus keeping it outside? And I think that's honestly just the effort of getting that integration into the EHR. But I do know that there's lots of people that do it. And if they're able to do it, they have a lot of success with that. So we can go on to the next slide. And then the key points here, challenges being knowing how to refer or who to refer to within the community, and also having a plan in place on how to follow up to ensure that those appointments have been adhered to. And some successes with that were, again, utilizing the right workforce on your staff, having the enabling services or the non-clinical staff members develop a resource guide and adapting that by health center needs and for the community needs. And also just understanding how SDOH can impact those care plans and using that data to understand the impact on the individual levels for a person-centered approach. And then again, to address capacity, using the data that you're collecting to identify what partnerships are needed, what community resources would address or could address some of those needs, and then instituting and standardizing referral practices. And then finally, using the data, as several others have mentioned, to access the funding. And as Sakura said, the Uniform Data System, the UDS Enabling Services data collection is not currently robust. As she said, there's only those 8 domains that are currently collected. But if you're able to utilize the toolkit that Albert posted in the chat, if you're able to increase that data collection, it demonstrates higher impact and higher need to create the partnerships and the proposals for other resources to enhance and improve your data collection and enabling services response performance. And I believe I also saw a question in the Q&A about how some of those consultations are listed. And I know that the toolkit does break down like group settings versus individual settings, behavioral health, and things like that. So that can be addressed through that toolkit as well. And then the next slide here. So I also then just want to touch on what you do with the data once you have it, and just some different ways that you can visualize that, either for yourselves or your organizations, where so that you can see the gaps and the needs that exist. Also considering, what is the story that you're wanting to tell, or what point does your data support, and how you can best demonstrate that graphically. So it's easy to digest for your stakeholders or for your communities. You can either use it to create internal dashboards for your providers or other staff, or public-facing dashboards. Brochures could be used for end-of-year reports to your stakeholders, all kinds of different things. So I just have some examples. You can move forward of how we've recently used it in the last year. Just some context for this. These examples are in relation to COVID testing and vaccination events. The council partnered with the CDC to get this data out there. But these are just meant to be examples. They can be tailored to other determinants. And also, just as a point of reference, we know that SDOH impacts the susceptibility to COVID. So if anybody's interested, this is a public link, it's available, and this data may be of interest to take back to your own health centers as they relate to your communities, or if you know of continued testing events or vaccination events. These links are still open, and they can be shared if anybody wants to input some of that large testing data. That would be great. But this is just an example of what the dashboard can look like. This is through a program called Infogram. We just import the data into that. I believe we update it now monthly. And then the summary is ongoing and longitudinal, aggregated, of course, but we can see just over the months what these results look like. We can see our total events, total tested, our positivity rates, breaking that down of symptomatic versus asymptomatic patients. And again, we're also developing or continuing to build that with our vaccination data. And then just moving on to the next example, pretty standard things like bar charts, breaking things down by the reasons for testing, shelter testing, location sites, things like that. But really just showing these to show the different types of ways that the data can be presented. You can move on to the next slide. And they do allow a lot of different ways to compile the charts where you can get those comparisons and see different ways that things can be broken down. And then the last example here is just, they have really cool mapping tools. I was thinking that this could be something that if it could be broken down into a state level or a county level, even community levels, if that's appropriate, to be useful for things like hotspots or outbreaks or phases of different implementations. So those were just some examples of how data can be visualized. And then another tool that we have is something that was developed by Lauren Berner, who's a research manager at the council, and it's a model called the Change Map. And we have been using these to model our learning collaboratives after. So I just wanted to go a little bit more in depth of how these address the questions that are relevant to how you would implement a program. So these are either implement a program or to assess, evaluate, and update an existing program. So the questions that have kind of been addressed already over the course of the webinar are broken down into these key areas to consider your steps for success. So your background, what's your action plan, what support do you need, what are the details that you'll need, and how you'll monitor that, which goes into how we will utilize our data. So you can go to the next slide here and just see how those questions then correlate to this map. And I just want to, once we get the screen shared again. Should be slide 81, Hansel. Perfect. Yeah, so those domains broken down into just a map kind of workflow. And if you hit next, again, it should just highlight that as we go through, we'll be using this for our upcoming learning collaborative. We would want people to be thinking about what data they'll need, how they can track it, all for the intent of sustainability, kind of as they think through each of those other sections. And then this is just an example from a previous health site that participated in a learning collaborative, how their responses to those guided questions are plugged in. And then these change maps are then provided to the participants at the end of the learning collaborative, and they have something tangible that they can take back to their health sites. A lot of folks said that they would use these or refer back to these during all staff meetings or during planning meetings if they were developing a new program, or again, just going back and looking at an existing program that could be improved and what they might need to improve that. And then on the next slide here, just highlighting that by this point, you've really successfully drafted all of the key components that are seen in most funding proposals or other types of grants or community projects. So the work that you do within the Learning Collaborative or just through this change map tool can then be applied with an aim to implement at your own sites and potentially find community funding that this could be written as a proposal for. And then just again, reiterating that last year, the organizations represented here, we led a learning collaborative and we utilized that model really effectively. And the focus on that was, again, identifying the strategies and the workflows just to screen for the SDOH and how to address them. But this month, starting in just a couple of weeks, or actually no, this month, we just put out a publication that highlights the lessons that were learned from that and highlight some of those organizations' work and the change maps that they created to share with others. So we can go to the next slide. And as several of us have mentioned, we do have another learning collaborative coming up in a couple of weeks. It's going to start on August 4th, will be our first session. And we're going to build off of last year's experience. So we're inviting health centers and other lookalike centers that serve special and vulnerable populations. This is going to, again, explore the strategies to screen for SDOH, but also then with a focus on how to utilize that data to enhance the provision of outreach and enabling services. And so that application is still open. It's open through July 26th. And you don't have to have participated in the previous learning collaborative to participate. But if you want to go back and take a look at that publication from the previous slide, just to get a sense of what is covered or what might be built upon, feel free to do that. And also folks who did participate last year are also welcome to return if any of you are here with us on the webinar, because we would love to hear about how you're continuing your process or your progress and what your next steps are. And I think that takes us to the end where we can open this up for us to address questions in the Q&A.
So at this time, if you guys have any questions, concerns, comments, this will be the appropriate time or the best time for you to go ahead and voice those, and we will try our best to answer any questions, concerns, comments that you might have.
So I see some questions where we've definitely decided to answer live. So I just want to read them off really quickly. So Amelia has a question that says, are there disadvantages to building SDOH screening directly into Epic? And are there any examples one way or the other? Albert, would you like to answer this question?
Oh yeah, sure. I gave an answer to the person, but just for the audience here, again, there are of course a lot of trade-offs if you are using a standardized tool like the Accountable Health Communities tool, Prepare, Health Leads, you name it. There's an opportunity to do a lot of aggregation with other similar users of those standardized tools. But if you're building it into your EHR, that gives you the customization and the advantage to really collect the data that you need for your organization, for your payers, for your policymakers. But again, want to emphasize the different standardized screening tools out there have really built a big and strong support network. And for a lot of you who are using, Prepare on this call today, there are so many training opportunities for you to kind of do peer-to-peer learning. And so I know that's the similar situation for the Accountable Health Community CMS tool, for your health leads tools, and any of those other ones that we mentioned earlier in the discussion. So yeah, I hope that helps.
Thanks so much, Albert. And then Joshua has a question. Is there national lobbying going on to make these points to decision makers like legislatures who can have an impact on Medicare or Medicaid? These seem like important topics for legislators, managers, and administrators. I'm really interested in best practice around SDOH data, quote unquote, on the ground to best impact individual patients. In my case, using Prepare, but also in best practice around the how to use or administer SDOH evaluation tools. And I'm a CHW at an FQHC. Bellany, you also said you're going to answer this question live. I'll pass it to you. And also folks, feel free to answer in the chat box as well.
Thanks, Sakura. Yeah, I think I can address part of this question, and I'm going to also throw it out to my other NTAP colleagues. And it looks like we also had some colleagues in the chat box that responded to this as well, talking about the launch of the now I've lost it. The SDOH caucus, the Congressional Social Determinants of Health caucus. And there's a link in there for a webinar as well as a comment form. So I think that would be a great resource to check out. But what I would say is that I think, because a lot of reimbursement comes through Medicaid at the state level, I think a lot of the lobbying and advocacy really happens on that level, because especially with the help of PCAs and other folks who can kind of help maneuver with state legislators, you can really kind of help to influence your Medicaid policy. I think the biggest example being the Medicaid expansion. And that really just happens on a state-by-state basis. But I think, if you're talking about national lobbying, one of the things that I would throw out that both Sakura and Brett mentioned is really just standardizing the enabling services categories, and especially the expanded categories, because I think that will really help to kind of build the database of information that national legislators would really need to understand kind of what the population health needs are. And again, I will turn that over to any of my colleagues who might have something additional to add there. But that's a great question. Thanks, Joshua.
Yeah, I was only going to add, depending on the population that you guys serve there, Joshua. We do have a policy committee with the council that's also led by our Senior Director of Policy, Barbara DiPietro, and also her other staff member, Regina Reed. If you're interested in joining something like that, you can always reach out to me and touch base with me offline, and we'd be happy to connect you to a group like that to kind of hear more about what they're doing.
Yeah, thanks so much, Brett and Bellany. And these slides will have our contact information as well. So if you want to follow up, please feel free to reach out. And then John had a question, ENUF, Enough Inc., I think I'm pronouncing it correctly, is asking how this information can help us do transitional housing for the medically vulnerable. Brett, I actually think this is before you presented, but if you kind of want to reiterate again, that'd be helpful.
As we all keep saying, I think that just having the data to demonstrate the need is always important. I know that a lot of folks, I kind of would defer also to our work that we do with the Corporation for Supportive Housing, but kind of hearing from those housing providers how they're able to utilize the data, to prioritize people, for available housing that they might have, or just finding where the needs are for those housing, for those who need housing. It's important to just have that ready to demonstrate, I think would be the simplest answer for that.
Absolutely. Thanks so much, Brett. And then there's another question. Do others offer patient vouchers for pharmacy, dental, transportation to assist patients with unmet service needs? By others, I'm assuming other health centers, and my other colleagues in the room can answer this, but I know some health centers, for example, make contracts with ride-sharing services like Uber or Lyft to help bring their patients to appointments as necessary. Did anybody else want to kind of add on to these questions? Let's see. All right. Yes, thanks, Albert, for putting the Gravity Project in the chat as well. And I see Myra, if I'm pronouncing it correctly, I see you have your hand raised. Did you want to unmute to ask a question? Can you hear us, Myra? I think you can talk now. Oh, okay, got it. Let me mute you back. Sorry about that. And then I see Dory responded, my center offers 330B pharmacy vouchers. Very cool. Dory, did you want to expand on that anymore? Let me see if I can unmute you a little bit. I don't know if it's working. But yeah, thank you for the questions and comments. Let me see. Maria said, oh, sorry, there's another question before. Didi, is there any consensus about language? We use social and economic barriers to health. Enabling services is also good, but we don't use SDOH because of the implications of determinants. Albert, did you want to answer this question?
Yeah, as a precursor, I pasted in a link from the American Academy for Family Physicians. Sorry, get mixed up with my acronyms, but they have really called on for a standardization around the use of SDOH versus social needs versus social risk factors. So take a look at that. That's something I reference a lot in various trainings, and it's really helped me contextualize for myself, but also for audiences who are really confused about when to use what. So just want to, shout out to Didi for highlighting that, because it's really important to be on the same page when we're talking about social determinants. And, when you talk about social needs, that really is built around addressing some of those, screening questions that have screen positive, like whether it's food insecurity or housing instability. And those could be considered social risk factors too. So read that article. It's really helpful and short and sweet.
Awesome. Thanks so much, Albert. And then Maria has a question that says, the needs of housing in Connecticut is on a high demand. And is this the same in other states? Brett, could you kind of answer from a national perspective? And I know you also work with PCAs and stuff, so to kind of give that state perspective as well.
Sorry, can you repeat the question?
Yeah, the needs of housing in Connecticut is on a high demand. And is this the same in other states?
Oh, yeah. I would definitely say that it's high in other states. I know that there are some areas, just to give an example off the top of my head, that they have really cool programs in place. I know Hawaii is one that's doing it, where they treat housing as a health condition, and so they have that model in place to prescribe housing to folks as it's available. And I think that's a really interesting way to kind of cut through some of the red tape of that. But yeah, again, I would kind of defer to some of my other colleagues that work more directly with CSH on that. But if there's follow-up questions about that or you'd like to connect with them, I'm happy to make those connections offline.
Yeah, I love seeing SDOH being actually implemented on a state level again too. And then I see Dory in the comments saying, yes, in Wisconsin, the demand is high, especially in poorer counties with their behavioral health population. Absolutely. So going right back to what we're talking about today, this is definitely very, very relevant. Let me see. And then, are there any other questions I'm missing, team? I think everything has been answered. So any other question, folks? I'm going to give about 10 more seconds for folks to raise their hand or type anything out. Otherwise,
hand raised. Sakura Kelly,
okay.
I think, has their hand raised.
Sorry about that. Yeah, okay, Kelly, let me unmute you.
Oh, another hand raised. Okay.
Let's see. Kelly, can you hear us?
Hello.
Hi.
Hi, this is Naja Kojo. I'm enjoying the forum today. Thank you very much. My question is, here in Louisiana, we have a really large population of homeless, and we were talking this morning in reference to ways, more creative ways to come up with housing for so many of these clients. Do you have any suggestions? Since you said that Hawaii treats this as a health condition, I'm not sure if that's a part of our legislative process right now, but we could sure use the help of some creative ideas to help.
Yeah, so yeah, I mean, as Bellany said before too, I think a lot of it is what's available, obviously, at your state levels and what the legislations are there. I know that I don't know how this has continued kind of as the pandemic has shifted into its newer phase. But, you know, a lot of the folks that were placing people in hotels kind of for the recovery and the quarantine, a lot of those have been extended and sort of repurposed into continued supportive housing or temporary housing. So I know that's an approach that some are taking. Just kind of trying to hold on to the resources that were made available during the last year. So just sort of, if your state also has a continuum of care, a COC group that you could connect with, they would also probably have a lot of people from different agencies and platforms and perspectives that could also provide insight on other initiatives that might already be going on or different resources that you could get connected with. So I would recommend just looking into a local COC. I don't know.
Thank you. Mm-hmm. And also, will this be available through email that I can maintain this and go back for reference?
The slides and our contact information, absolutely.
Okay, thank you.
Thanks so much, Brett. And I know, Albert, you also have a connection with Louisiana PCA too. So I thought about that really quickly when I heard their question.
Yeah, definitely for the house centers, all the primary care associations in all 50 states, but also regions in the Midwest have a policy and advocacy kind of arm where they're really trying to get a hold of like all the different types of information and data you're collecting on social needs. And housing data is one of those that is really needed to do a lot of advocacy at the state or regional level and even national level, since it's a longer term game, whereas food insecurity is an easier short-term game to develop partnerships. So let's all continue supporting each other around the housing piece because it's really, really complex and it varies by state.
Thanks so much. And thank you everyone for your amazing questions. And we want to respect everyone's time and acknowledge that there's only a minute left. If you could please take the survey that Albert put in the chat, it would really, really help to continue improving our work and to also apply to our learning collaborative that's happening really soon. Albert, if you could drop that in the chat again too. We're taking applications until July 26th, I believe. And it's a really great way of what we're going to work on a change map that Brett had referenced